All right, hello everyone. Today we are going to be talking about chapter 14, which is dealing with the blood. Here you can see some of the roots, prefixes, and suffixes that we'll be going over in this chapter. Some of these you've already are familiar with or have at least heard of. I'm sure you've heard of bilirubin, hematocrit, embolism, erythrocyte, ERYTHR means red, hematoma, hemoglobin, hepatocyte or hepat means liver, leukocyte, that'll be white blood cell. We already talked about lyse. LYS means to break up, macro means large, poly means many. We've talked about homeostasis. A thrombocyte is a platelet. So some of these you're already familiar with. Just know that we'll be committing these to memory, so you'll have to learn some of these. All right. So blood itself. Remember way back when we talked about connective tissues, and so blood is actually a connective tissue inside this thing called plasma. Now, plasma is just a mixture of substances dissolved in or suspended in water. It has gases, amino acids, proteins, carbohydrates, lipids, vitamins, hormones, electrolytes, a bunch of cellular waste. Um, and the blood transports, we know, vital substances, and it regulates processes for homeostasis. So it transports that oxygen. It gets rid of the carbon dioxide. You eat your Big Mac. The digestive system processes the Big Mac into energy, fats, carbs, lipids, and all that stuff. And the blood has to transport it to wherever it needs to go. It maintains the stability of the interstitial fluid. Remember, we have that intracellular fluid, we have that extracellular fluid. And I mentioned a while ago that several chapters ago that the arterial side will dump out about 20 liters of fluid every day. The venual side will bring back 17 liters of fluid a day. And we have this 3 liters of fluid that kind of just sits out in this interstitial space that's usually picked up by the lymphatic system. And if it's not picked up by this lymphatic system, you'll get what's a condition called edema. And we'll get into more of the physiology behind that later on in subsequent chapters. But so that's just kind of like where interstitial fluid is, or that interstitial space. So pH of the blood, here it says 7.3 to 7.5. I will say that this textbook is one of the only textbooks that I've seen that says 7.3 to 7.5. I have always learned that the blood pH is 7.35 to 7.45. So for the purposes of the exam, we'll say is 7.3 to 7.5. However, when I talk, I will probably say 7.35 to 7.45. Because that's just how I learned it. All right, so we know blood can distribute heat. Skeletal muscles contract, skeletal muscles use ATP. When we break down ATP, we go ATP yields ADP plus PI plus energy in the form of heat, that the blood has to distribute that heat to various parts of the body. Blood volume is going to varies with size, shape, body composition, electrolytes, percentage of body fat or adipose tissue. And blood's about 8% of your total body weight. We say it's about 4 to 5 liters in females or 5 to 6 liters in males, just because males are typically bigger build or taller than females. Always doesn't mean always, never doesn't mean never. But roughly, you can guess about 5 liters. If you just say 5 liters of blood, you're probably in a good ballpark to say that number. So for blood cells, we have red blood cells. They are called erythrocytes. White blood cells, they're called leukocytes, and platelets are called thrombocytes. And all platelets are just cell broken up cell fragments, usually cytoplasm. Um, and if we take red blood cells, white blood cells, and platelets, we are saying that those are formed elements. Those are actually produced in the red bone marrow by the skeletal system in bones. So, all right. So here is a picture representation of kind of how the blood is broken down. So here you can see blood is about 45% of the formed elements and 55% plasma. And remember, plasma is just that mixture of dissolved substances or substances that are suspended in water, such as, electrolytes, water, proteins, wastes, nutrients, vitamins, hormones, gases. And so for formed elements, remember we have red blood cells, white blood cells, and platelets. Red blood cells are going to be the most abundant. You don't have to memorize percentages. Remember we have 5 different types of white blood cells: neutrophils, eosinophils, basophils, monocytes, and lymphocytes. Remember that in order to remember the order of white blood cells in order of largest to smallest. Never let monkeys eat bananas. So neutrophils, never let monkeys eat bananas. All right, so whole blood, when we're looking at just like whole blood by itself, whole blood is actually about 3 to 4 times more viscous or thicker than water is. It's a little bit heavier than water. If blood is too thick or too thin, the heart will have to work a little bit harder to pump. Here we can see blood is 92% for the plasma side. It's 92% made up of water. And we can see within proteins, we have albumin. Albumin is the main function of albumin is just to maintain this thing called colloid osmotic pressure. We'll get into what colloid osmotic pressure is later on in subsequent chapters. And let's see. So that's about it. Gases, we breathe in oxygen, we breathe out carbon dioxide. So we'll talk about a little bit more of these later on. All right, so when we go to the doctor's office, nurse practitioner's office, whatever, we get our blood drawn, and they actually kind of put it in this machine, and they can spin it down if they want to, and we can separate it out. So we can see that we have this plasma, which is about 55% of our blood volume. We saw that here. Our red blood cells make up about 45%. So 45% of our red blood cells, or it's a little bit less because remember our formed elements make up 45%. And then our red blood cells make up 95% of that. But we can pretty much approximately say our red blood cells make up 45%. And then we have this thing called hematocrit. And basically our hematocrit is the percentage of red blood cells. And then typically the hematocrit, red blood cell count, and hemoglobin concentrations are going to be higher in males when compared to females. And then we also have white blood cells and platelets, and they're going to make up less than 1% of your blood volume, and we can kind of see that represented here in those numbers. All right, so here, when we get your blood drawn, we throw it in this thing called a centrifuge. And when we spin it down, we can see that our plasma is here, Our red blood cells are down here, and this little area right here, we call that a buffy coat. That's actually where our white blood cells and our platelets are going to lie. Okay, we've all heard of universal precautions. We have to follow those in lab if we're working at the patient's bedside. Basically, these are, and this is just a textbook definition, a set of specific measures that healthcare workers take to prevent transmission of bloodborne pathogens in the workplace. It's used basically because you don't know what your patient has, and your patient might not know if they have a condition that can be transmitted to you or to other patients. So protect yourself, and on the same time, on the flip side, you don't know if you have something that you can transmit to your patients. One of the things that we are really dealing with now is fingernails, acrylic nails, or nails that are really too long. Typically, we say if you turn your hand backwards, your nail should only be 1/4 of an inch past your finger. And a lot of people don't abide by that. And that's because, and what we see is that bacteria get underneath your nails, and you can transmit that bacteria to your patients. So, and with the acrylic nails, as your nails start to grow, a lot of bacteria can fill in that gap there. And we found that, healthcare workers especially don't do a good job of washing their hands. So that's another reason why we came up with these universal precautions. So depending on what activity you are doing with your patient or what activity you're doing in lab, that will dictate what universal precautions you have to use. Sometimes gloves are appropriate. Sometimes you have to use gloves, gown, mask, goggles. Again, depending on what you are doing with your patient or in lab. And I will say it's a little funny story. It's not funny now. But when I was maybe fresh out of high school, when I went through the CNA program, we actually wore 3 pairs of gloves, and you worked with this patient, took off a pair of gloves, worked with this patient, took off a pair of gloves, worked with this patient, took off a pair of gloves, washed your hands, put 3 pairs of gloves on, worked with this patient, took off a pair of gloves, worked with this patient, took off a pair of gloves, worked with this patient, took off a pair of gloves, washed your hands. Obviously, we don't do that anymore. Okay, so formed elements. Remember, your formed elements are red blood cells, white blood cells, and platelets, and they originate in the red bone marrow of the skeletal system of long bones and some other bones. But they originate in the red bone marrow from these stem cells called hematopoietic stem cells. And they're also called hemocystoblasts. And they give rise, basically these hematopoietic stem cells or these hemocystoblasts are going to give rise to more stem cells. And if you remember from, I think one of the chapters in AMP1, we talked about the different types of, pluripotent, totipotent stem cells. So these are a type of stem cells. And so basically, these hematopoietic stem cells are going to give rise to more specialized or more differentiated stem cells that will allow more growth of these red blood cells, white blood cells, and platelets. So we have these lymphoid stem cells that are going to give rise to lymphocytes, and we have myeloid stem cells that are going to give that are going to differentiate into red blood cells and to other types of white blood cells and platelets. So here you can see the hemocystoblaст. So that's your hematopoietic stem cell, your hemocystoblast, and that So we can see that your lymphoid stem cell is going to give rise to eventually, your lymphoblast, and then your lymphocytes. So your monocytes, your T cells, and your B cells. So your lymphocytes. And then we also have your myeloid stem cells, which are going to give rise to eventually your red blood cells, some more white blood cells, because remember, these are, and we can see the pathway here. I guess I shouldn't have let me do some erasing. Pen. So there we go. There's our lymphocytes. There we go. So there are some white blood cells. So 4 out of the 5 white blood cells are going to come out from this myeloid stem cell. And we can see that they come from platelets. So your myeloid stem cell is going to give rise to monocytes, neutrophils, basophils, and eosinophils, platelets, and erythrocytes. So lymphoid stem cells are basically going to give rise to lymphocytes. Do you have to know all of these intermediate steps? Not really. But you do have to know kind of like the overall what is going to happen. You do have to know, and I will just kind of erase what all I've done, and for testing purposes, I'll tell you what you need to know. So you will have to know the order you will have to know this order. You will have to know the hemocystoblast is going to go to the myeloid stem cell, through the erythroblast, through the reticulocyte, through the erythrocyte. You will have to know that that these granulocytes, basophils, eosinophils, and neutrophils descend from this cell called a myeloblast. One thing I will talk about is this thing called nuclear extrusion. Basically, when erythroblasts, which those are right here, when erythroblasts divide and give rise to new cells, the new cells synthesize hemoglobin, and the nuclei of these newly formed cells, they're going to shrink and are pinched off. The nuclei are going to shrink, and the nuclei are pinched off from the cell along with a thin covering of cytoplasm and cell membrane. So the nucleus kind of disappears. And this nuclear extrusion is going to happen with erythrocytes. So you can see that erythrocytes, or red blood cells, they don't have a nucleus. So at this step, erythrocytes have had this nuclear extrusion happen to them, so they don't have a nucleus. One other thing that I will point out is that erythrocytes or reticulocytes, I guess I would say, enter the bloodstream as erythrocytes. And I think that's the last thing I'll point out from here. If there is something, I'll come back to this slide, but I think that's it. All right, so red blood cells themselves, we call those erythrocytes. They have a biconcave disc shape. So bias to concave means that it caves in on itself. So you can see how kind of like it, you can see how it caves in on itself here, and it caves in on itself here. So it's biconcave. It has 1/3 hemoglobin, which transports oxygen. So we have we have this thing called oxyhemoglobin, which is with oxygen, and deoxyhemoglobin, which is without oxygen. So hemoglobin itself can kind of be classified into oxyhemoglobin and deoxyhemoglobin, depending on whether or not oxygen is attached to it. And remember, red blood cells do not have any nuclei, and they do not have mitochondria. So therefore, red blood cells do not divide. When a red blood cell is done with its lifespan, it's done. It's dead. It doesn't replicate, and so it'll go. It'll go and it'll get eaten up and it'll die, and the skeletal system will produce more red blood cells. But it does say that it can produce ATP through glycolysis. Now remember, glycolysis is an anaerobic process, and that's going to happen in the cytoplasm. Remember, aerobic respiration happens in the mitochondria. So since red blood cells do not have a mitochondria, we can't do aerobic respiration, so red blood cells can only do glycolysis. So going back to here, this oxyhemoglobin and deoxyhemoglobin. If we have too much deoxyhemoglobin, so let's say that our blood concentration of deoxyhemoglobin is too high or abnormally high. So we're not breathing in enough oxygen, or let's say that we have impaired gas exchange that doesn't allow our oxygen to go from our lungs to our bloodstream. Let's say we have asthma, or we have pneumonia, or we have cystic fibrosis that prevents oxygen going from our lungs to our bloodstream. So we have a lot of deoxyhemoglobin. So if we put our little pulse ox on our finger and it says, let's say it says 88%, or if it says 82%, typically when you put your pulse ox on your finger, it should say, 98%, 99%, 97%. You can see a condition called cyanosis. Cyanosis is basically low oxygen levels. So if you have too much deoxyhemoglobin, you could actually see this condition called cyanosis. All right, and we've looked at the red blood cells already. Okay, so red blood cell count. It's measured in cubic millimeters or microliters of blood. So here you can see your typical ranges: 4,700,000 to 6,100,000. In males, 4,200,000 to 5,400,000. Females, and we can see for children. So we don't say, oh, my red blood cell count was 5,312,412. Basically, when we say red blood cell count, we say, my red blood cell count was 5.2. My red blood cell count was 4.93. That's kind of like the lingo that we use. So if you look at like the averages of all of these, as long as your red blood cell count is around 5, typically we say that will be a good number. So if you have to remember one number for red blood cell count, remember the number 5. Okay. All right, so red blood cell count, useful in diagnosing basically conditions involving your red blood cell count. And changes in your red blood cell count can reflect, or does reflect, changes in blood oxygen carrying capacity. So if we have a high red blood cell count, we have a condition called polycythemia. If we have a low red blood cell count, that's called anemia. Now we have several different kinds of anemia, and we'll talk a little bit about those later on. But with anemia, Anemia, remember, is low red blood cell count. And I know we haven't talked about, the makeup of red blood cell count. We haven't talked about hemoglobin really. We know that hemoglobin is inside of red blood cells. And hemoglobin is what oxygen attaches itself to so that oxygen can get into the tissues and into the cell at the cellular level. So oxygen is bound to these hemoglobin molecules and gets transported by red blood cells. So if our red blood cell count is low, then we would assume that our oxygen carrying capacity is reduced. If we have a low red blood cell count, then we have low hemoglobin, then we have low oxygen delivery to the tissues. So that to me makes sense. Now, what happens if let's say that we have a normal red blood cell count, but we have altered hemoglobin? That would also reduce our oxygen carrying capacity. So just because we have, so basically so anemia is not necessarily a low red blood cell count. Anemia can also be a condition. Anemia really is defined as a condition in which the oxygen carrying capacity of the blood is reduced. So it could be due to a low red blood cell count, but it also could be due to a defect in hemoglobin. All right, so we talked about the counts in males and females, and I think I said before, if we measure our hematocrit, red blood cell count, and hemoglobin levels, typically they are going to be higher in males compared with females. All right, so erythropoiesis. Basically, erythropoiesis is how our body makes red blood cells, and that occurs in the red bone marrow of bones. So if we have low blood oxygen levels, we call that hypoxemia, and we talked about cyanosis a couple minutes ago. So low blood oxygen levels or hypoxemia are going to cause your kidneys and your liver to release this hormone called erythropoietin or EPO. And that's going to stimulate red blood cell production. And then hopefully your kidneys are going to produce these red blood cells. And it's going to it's a negative feedback mechanism. So once your body's going to release this erythropoietin to create red blood cells, and once we have enough red blood cells, that erythropoietin is going to shut off. So that's your negative feedback mechanism. And then hopefully after a few days of EPO secretion, you're going to see new red blood cells appear in the blood. And we talked about the stages of development of a red blood cell back up here. And so we're not going to rehash that. Immature red blood cells enter the circulation as reticulocytes. So here, erythrocytes, immature red blood cells enter the circulation as reticulocytes. So that you will definitely need to know. Immature red blood cells enter the circulation as reticulocytes. And we see that the lifespan of an average red blood cell is 120 days. So average month is about 30 days. So around 4 months. So usually we say, 3 to 5 months for a red blood cell, or here 4 months would be average. So remember, red blood cells, they don't divide. So once they're dead, they're dead. They go off to someplace and die. Um, and with EPO, or erythropoietin, we talked last chapter about athletes abusing this erythropoietin, or EPO. Basically, that's going to increase the red blood cell supply, and it's going to bring more oxygen to the muscle cells. But it does come with a lot of consequences. We talked about, increase in heart attacks, stuff like that. So some of the nutritional requirements for erythropoiesis, remember, we are growing red blood cells. So we are going to need vitamin B12, folic acid. We need that DNA synthesis. We're going to need proteins, amino acids, anything necessary for growth and division of cells. Iron. If we're creating red blood cells, we need iron, because we have to also create that hemoglobin to go into the red blood cells. And I know, like I said, I know we haven't talked about hemoglobin. We will in like 7 slides or something like that. All right, so here is just the pathway for red blood cell production. So low blood oxygen levels are going to stimulate the liver and kidney to secrete this erythropoietin into the bloodstream. Erythropoietin is going to stimulate the red bone marrow, and that's going to result in an increased number of red blood cells, and hopefully will increase your oxygen carrying capacity. And then the increase in red blood cells, that's going to provide your negative feedback loop and inhibit erythropoietin secretion. Now, remember, we talked about polycythemia, which is an increase in red blood cells. And so with polycythemia, that's going to be caused by cancer, maybe tobacco smoking, dehydration, high altitudes. Polycythemia can also increase your blood viscosity. Remember, that's how thick your blood is, which is going to slow your blood flow. It can also increase your risk for developing clots, and it also overworks your heart. Oops. Okay, so here's just a table of, we talked about what is required for blood cell production, vitamin B12, iron. But so here's just a little table. So B12, it's absorbed from the small intestine, and it's going to be used for DNA synthesis, but it also requires this intrinsic factor for absorption from the small intestine. Iron is going to be used for hemoglobin synthesis. It's also absorbed from the small intestines, and folic acid is going to be used for DNA synthesis. It's absorbed from the small intestine as well. But this intrinsic factor, it's basically a special protein called intrinsic factor, and it binds this vitamin B12 so that it can be absorbed in small intestines. It's a protein released by cells in the stomach. And when the stomach does not make enough intrinsic factor, the intestine can't properly absorb vitamin B12, and this deficiency can affect red blood cell production by causing the bone marrow to form abnormally large, irregularly shaped, thin membraned, very fragile red blood cells. All right, so we talked about anemia, and I said that we have several different types of anemia. So here you can see, basically hemorrhagic anemia. Remember, anemia is either low red blood cells or an alteration in hemoglobin. Really, the true definition of anemia is a condition that affects your blood carrying capacity or that decreases your oxygen carrying capacity. So anemia, oxygen carrying capacity, and typically it's going to be low red blood cell count. But not always. So hemorrhagic anemia, we're not talking a paper cut, but let's say so we have 5 liters of blood. So if you cut yourself and you lose 1.5 liters of blood, so now you're down to 3.5. That's going to be due to hemorrhage. You have really decreased your number of red blood cells. Hemolytic anemia. That's usually a result of bacterial infections. Or it could be blood transfusion reactions. We don't see those too much nowadays. Pernicious anemia, that's when we have that intrinsic factor that causes inadequate vitamin D absorption. You're going to see that more from like anorexia. Aplastic anemia, you're going to see that more from cancer patients, radiation, maybe some medications. It's where you have destruction of, bone marrow transplants. Here, decreased hemoglobin conditions or concentrations. Iron deficiency anemia. Remember, iron is required for hemoglobin. So if you have dietary malnourishment, if you don't eat enough red meat, heavy menstruation can actually decrease your iron count, or if you have a persistent bleeding ulcer in your stomach. Also, abnormal hemoglobin, sickle cell anemia. We'll look at sickle cell a little bit on the next slide. Basically, it's a defective gene that leads to an abnormal hemoglobin structure. Thalassemia. Thalassemia is seen more in the Greek population. It's also going to affect your hemoglobin where your red blood cells are very short-lived. Remember, your red blood cells live for about 120 days, which is about 4 months. So what do you need to know from for testing purposes for my exam? You will need to know aplastic anemia. You will need to know iron deficiency anemia. Vitamin C, citric acid, will help increase iron absorption into your body. Where's iron? Iron. Yeah, so vitamin C will actually help increase iron absorption. Also citric acid. Tannins, oxalates. So if you drink tea, if you're on iron supplements, vitamin C is good. It will help iron go into your body. Tea is actually bad for you. Tea, the oxalates and tannins in the tea can actually inhibit iron absorption in your body. So remember that the definition of anemia is either a decreased number of red blood cells or a reduction or an alteration in the amount of hemoglobin. But overall, it's going to be a reduction in the oxygen carrying capacity of the blood. So when you look at, if you have a patient who is anemic, they could look pale, maybe lack some energy. Those are going to be like your first 2 signs. So sickle cell anemia, here you can see some normal red blood cells. They're, nice and puffy. But here you can see the sickle cell. They're not nice and puffy. And we'll talk a little bit, I guess we'll talk about it now. So sickle cell disease, remember, is a genetic mutation which is going to code for hemoglobin. It's going to alter that hemoglobin structure, and those red blood cells basically form into sickle shapes. And those red blood cells then will, once they get into the narrow vessels, like the capillaries, they're going to become sticky, and they're going to stop blood flow to those local areas, to those to the capillaries where they kind of get stuck in. And this oxygen once they get stuck there, the oxygen can't get to those areas, which from those blockages, and it's going to lead to a lot of pain. So those red blood cells are going to die quicker, going to result in anemia, going to cause patients to have extreme fatigue. So a lot of these times, these patients are going to present to the emergency room in pain. And if you are going to become an emergency room nurse, don't assume these patients are drug seekers. I didn't know enough about sickle cell disease when I worked in the emergency room. I worked in the emergency room as a tech, as a CNA, before I went to nursing school. And I was under the mindset of my nurses, because they're the ones who taught me, that these patients were drug seekers, and they were not. Give them oxygen and give them pain medicine. That's what they need. They need oxygen, fluids, and pain medicine. And it's really gonna help them out. Usually these patients are under social worker care. They know their condition. Yes, you're gonna have your drug seekers out there, but the majority of patients, they know their disease and they know what is best to treat their disease. And so some of the treatments that you can give, children, if we know that they have sickle cell disease at birth, we can give them some antibiotics. If we know at birth, we can give them this thing called hydroxyurea. We can do bone marrow transplants, but bone marrow transplants, they're really, really expensive. So most of the people are not going to get bone marrow transplants. And then we do have some research out there, but basically all we are going to do is treat the symptoms and provide education to the patients on how to prevent sickle cell flare-ups. And sometimes we can't. All right, so death and destruction of red blood cells. So I said that red blood cells, they're going to die after about 4 months, 3 to 5 months. And so what happens? I said they go somewhere to die. Where is that somewhere? So after about 4 months, they're going to lose their elasticity. They're going to become fragile. They can't reproduce. They're going to go to either the spleen or the liver, and they're going to get ruptured. They're going to be phagocytized. They're going to be eaten up by these things called macrophages. And what's going to happen is this hemoglobin, remember hemoglobin is inside these red blood cells. So this hemoglobin is going to separate into into 4 different subunits. And we're going to have these globin chains with these heme groups. And these heme groups are going to break down into iron and biliverdin. And as a side note, I grew up with Sesame Street and Muppets and stuff like that. And there's this Muppet, the Muppet, the scientist Muppet Beaker. And every time I see this word biliverdin, I always want to pronounce it like that, the Beaker. And I always want to say like biliverdin. Anyway. All right, so heme is going to be broken up into iron and biliverdin. Iron is going to be transported back to the bone marrow because the body's going to reuse it. And this biliverdin is going to be converted into bilirubin, And both of these, biliverdin and bilirubin, is going to be excreted as bile. The globin chains are going to decompose into amino acids. Remember, the body is going to try and reuse what it can, and it's going to go back in the bloodstream. So remember, phagocytes. Phagocytes are just cell-eating macrophages, big eaters. So really, what I want you to remember is that we have this hemoglobin is going to get broken down into heme, which is going to get broken down into bilirubin, and then into bilirubin. All right, moving on. So here's just a chart form of what we just talked about. You can read that one on your own. We just kind of went through that. All right, so heme itself. So heme, when we look at it, heme has, or hemoglobin has, is basically like 4 different polypeptide chains kind of mixed into one. So you can see there's like 4 different color. Oh, I didn't advance your slide. There's like 4 different color purples in there. So you have, this purple, this purple, this purple, and this purple. And then, so we have the 4 different heme groups surrounded by this globin, and these two globin molecules have a beta chain, beta 1 and beta 2, and the other 2 have the alpha 1 and alpha 2. And then, over here in part B, it has a chemical structure of this heme group, and we have this central iron is going to be bonded to the 4 nitrogen groups, or the 4 nitrogen atoms that are further bonded to this compound, and they're all connected. So you can see the iron is going to be bounded to these 4 nitrogen groups. And then as we kind of break up the heme, we're going to break it up into this biliverdin, and we're going to release that iron. And then later on, we're going to convert that biliverdin into bilirubin. So iron is just a component of heme. All right, so what happens for life of a red blood cell? So we have the nutrients that are absorbed by the small intestine, and the blood is going to transport those absorbed nutrients. The nutrients and erythropoietin are going to be used by the red bone marrow to produce red blood cells. The red blood cells circulate in the bloodstream for about 4 months, and then the macrophages in the liver and the spleen are going to phagocytize and break down those old red blood cells. Then the hemoglobin is going to be broken down into globin and the heme, and the globin is going to be further broken down into amino acids that can be reused or recycled. The heme is further broken down into iron, which is either just stored or recycled to produce hemoglobin and myoglobin. We talked a little bit about myoglobin in the muscular system. Myoglobin is kind of like hemoglobin in the skeletal muscle cells. Then this pigment is converted to biliverdin, and the biliverdin is converted into bilirubin. And the pigment is, these pigments become part of bile or bilirubin derivatives and carried to the bloodstream, to the kidneys to get eliminated by the urine. All right, white blood cells. White blood cells are called leukocytes, and um, they protect us against diseases. They do have limited lifespan, so they're going to be replaced, and they develop from the hematopoietic stem cells in the red bone marrow under control of these interleukins and colony stimulating factors. Interleukins, I'll just say IL. Interleukins are just numbered like IL-1, IL-2, IL-3, stuff like that. Colony stimulating factors are named for the cell population that they stimulate. So like granulocyte colony stimulating factor, or macrophage colony stimulating factor. And we have, the 5 types of white blood cells. Remember, never let monkeys eat bananas. And we can divide the 5 types of white blood cells into how they appear and how their cytoplasm appears. Do they have granules or not? And if they do have granules, we can say that they are granulocytes. If they don't have granules, or they don't look like they have granules, when we look at them in a microscope, we say that they are agranulocytes. So granulocytes are neutrophils, eosinophils, and basophils, and agranulocytes are lymphocytes and monocytes. And I guess I should say that the interleukins and colony stimulating factors are the ones that actually stimulate the production of white blood cells. So, functions of white blood cells. So, white blood cells move through blood vessel walls towards infection sites, and that's called diapedesis. So here we can see that the white blood cells are actually kind of leaking through the wall of this capillary. That's what it means by diapedesis. So when the leukocyte from a blood capillary enters the tissue space, that is diapedesis. We have these cellular adhesion molecules, or proteins, that direct leukocytes to injury sites. White blood cells can be phagocytes, where they engulf digestion of pathogens. Remember that neutrophils and monocytes are very mobile, and they do phagocytosis, or that they are phagocytes. White blood cells are involved in the inflammatory response. It's a reaction that restricts the spread of infection promoted by basophils. Remember, basophils, they secrete heparin and histamine, and involves swelling and increased capillary permeability. Basophils are recruited to the site of inflammation. And remember, basophils are granulocytes. Basophils are granulocytes. So basophils release their granule contents like histamine, and histamine. So you're going to see a decreased amount of so once let me back up. So once basophils go to the inflamed area, you're going to see a decreased amount of basophils in the bloodstream. And then we have this thing called positive chemotaxis, and basically that is an attraction of white blood cells to the infection site by chemicals released by the damaged cells. So we have to be able to attract the white blood cells to the area of infection, and this thing called chemotaxis. All right, so We're going to look at a leukocyte or a white blood cell moving in the bloodstream to the site of this splinter in your palm, where it's required to fight infection. When it gets near the splinter, the leukocyte needs to slow down, and the bloodstream is very turbulent. Bloodstream moves fast. So a type of cellular adhesion molecule, or CAM, called selectin, does this by coating the white blood cell and providing traction. Then the white blood cell is going to slow down to a roll and binds to these carbohydrates on the inner capillary surface. Clotting blood, bacteria, and decaying tissue at the injury site releases these biochemicals called chemoattractants, like that chemotaxis, chemoattractants that attract the white blood cell, and finally a type of CAM, or cellular adhesion molecule, called integrin, contacts an adhesion receptor protein protruding into the capillary space near the splinter. The integrin then pushes up through the capillary cell membrane, grabbing the slowly passing white blood cell and directing it between the tile-like cells of the capillary wall. And then white blood cells that accumulate at the injury site produce inflammation and form pus along with the dying bacteria. All right, neutrophils. Remember, neutrophils are granulocytes, and they're going to look purpley when they're stained under the microscope. They have multiple lobes, their nucleus does. So you can see that there's like 2 to 5 lobes. We also call them polymorphonucleoleucocytes, or PMNs. You don't need to know that. But when we have an infection, your neutrophils are going to be the first one to arrive. That's because they're going to be the most predominant of your white blood cells. Remember, never let monkeys eat bananas. They're strong phagocytes. Remember, phagocytes are cell eating. And you're going to see an increase in neutrophils with bacterial infections, inflammation, and stress, like MRSA, vasculitis, inflammatory bowel disease, smoking, burns, pregnancy, and obesity are reasons for increased neutrophil count. Neutrophils, with phagocytosis, neutrophils kill bacteria by creating this thing called a respiratory burst. It's actually a toxic chemical cloud of oxidizing agents such as like hydrogen peroxide and bleach around the bacteria. And as the bacteria die, they are phagocytized by the neutrophils. All right, lymphocytes. Okay, lymphocytes are the smallest of the white blood cells, so they're slightly larger than red blood cells. They are agranulocytes, so when you look at them under the microscope, they don't have granules in their cytoplasm. We can break up lymphocytes into 2 categories, B cells and T cells, or B lymphocytes and T lymphocytes. We'll talk about those when we talk about immunity. So T cells actually directly attack microorganisms or different pathogens, tumor cells, transplanted cells. So they are going to attack against any foreign substance that enters our body. B cells are going to produce antibodies, and they can live for years. We'll talk about memory cells, so that when you encounter a virus, will produce, or a bacteria will produce memory cells, so that if we're exposed to the same type of virus or bacteria, we'll have those memory cells that can be activated, so that it won't take as long to start fighting off the infection for subsequent infections. And so these are very important for immunity. Monocytes, they're the largest of the white blood cells. They're very, very large. They're going to be larger than a red blood cell. They're kidney shaped. Their nuclei are kidney shaped. You can kind of look, and they have a little kidney bean shape. Um, uh, Stained purple. You don't see any granules in the cytoplasm, so they are agranulocytes. They will leave the bloodstream to become macrophages. They can live for weeks or months. Like I said, macrophages. They are going to phagocytize bacteria, dead cells, or debris. I'll look that one up. So monocytes eventually, or monocytes contain these things called lysosomes. Remember lysosomes way back from chapter 3 or 4? 3, I think, when we talked about organelles, are filled with these they're garbage disposals of the cell. They're filled with these digestive enzymes. They're going to break down organic molecules, like in bacteria. They're going to dump the contents into the cells. Monocytes are going to increase with viral replications and inflammation. Eosinophils, they are granulocytes. You can see the little granules in the cytoplasm here. Granulocytes, so they have 2 lobes. You can see the 2 different lobes of the nuclei there, the nucleus there. You'll see those with allergic reactions or parasitic infections. They are weakly phagocytic, so they do have some phagocytosis ability with them. Basophils, you can definitely see the granules or the granulocytes in the basophils in the cytoplasm. They're so big that the granulocytes can obstruct the view of the nucleus. And basophils release this thing called histamine. We've talked about histamine and heparin before, but histamine is going to stimulate this whole inflammatory process. And heparin is basically an anticoagulant to help stop blood from clotting. So, basophils play a major role in the allergic reaction process. You go outside, you breathe pollen, you get the whole cascade of, stuffy nose, and then you have to take an antihistamine or Benadryl to counteract all this basophilic activity. So when basophils release this histamine to stimulate this inflammation, that's going to increase your blood vessel diameter or vasodilation to speed up the blood flow to that area. But if you see a decreased basophil count, that would mean that the inflammatory response to the injured and infected tissues will be diminished. All right, so white blood cell counts is 3,500 to 10,500. We don't say your white blood cell count is 3,512 or 8,513. We still say your white blood cell count is 6.7, is 7.8, something like that. So approximately 4,500. We remember the number 5 from red blood cells. If you remember 5 or 5,000 for white blood cells, great. So leukocytosis is just an elevated white blood cell count greater than 10,500. You'll see this with acute infections. If you do a lot of vigorous exercise, emotional disturbances. Leukopenia is a low white blood cell count, less than 3,500. If you have that with flu, influenza, measles, mumps, chickenpox, anything that will decrease your immune system, HIV, AIDS, polio, anemia, And when we have an infection or if there's something going on, just having a white blood cell count number is a white blood cell count is not sufficient. So, a white blood cell count of 3,500 doesn't really mean anything. Um, you have to know so we do a differential. We look at the neutrophils, the basophils, the eosinophils to help determine what's going on inside our body. And so we look at those previous, slides of, what's going on to kind of help guide our diagnosis. So, neutrophils are increased during bacterial infections like MRSA. Um, helper T cells decrease during an HIV infection. So that will help us kind of help doctors, nurse practitioners kind of PAs guide us into more of a diagnosis. So here is just a little bit of a little chart. Definitely not an all-inclusive chart. So if you have elevated lymphocytes, you can see, maybe some leukemia, whooping cough, mono, eosinophils. You might have some tapeworm, hookworm, allergic reactions, monocytes elevated, malaria, tuberculosis, typhoid fever. All right. So with leukemia, is actually cancer of your white blood cells. We can classify it as acute or chronic. Acute just means that the symptoms appear very suddenly and progress rapidly, whereas chronic is more of a slow process. So it might be undetected for months or over years. And we can also classify it as lymphoid or myeloid. And remember, if we go back to wherever that chart was, here, let me just do some erasing. All right, so if we can classify leukemia as lymphoid, and lymphoid is a cancer of lymphocytes that are produced in the lymph nodes. So that would be an issue with here your B cells and your T cells. Myeloid leukemia would be a cancer of your granulocytes that's going to be produced in your bone marrow. So here, your basophils, eosinophils, or your neutrophils. All right. So basically, we have too many immature white blood cells. We have too many eosinophils. We have too many monocytes. We have too many something. And it's going to cause headaches, fevers, nosebleeds, fatigue, respiratory infection, bone pain, increased blood clotting time, increased bruising, increased bleeding. And typically, some of your treatments are going to be cancer, your cancer-related treatments such as chemotherapy or drugs that target those enzymes to treat cancer, or bone marrow transplants, stem cell transplants. So it's not necessarily that we have too little white blood cells. We might have, when we do our differential, we might have a normal count of white blood cells. We might have a normal count of eosinophils. We might have a normal count of neutrophils, basophils, and all that stuff, but they are immature in that they are non-functional. All right, and remember that polycythemia is just an elevated white blood count, whereas leukemia is polycythemia is an elevated red blood cell count, whereas leukemia is an elevated white blood cell count. All right, so thrombocytes, so blood platelets. Remember, platelets are just cellular fragments or cytoplasmic fragments of these megakaryocytes. Megakaryocytes. So here, megakaryocytes go into, I guess I shouldn't. There we go. Megakaryocytes get converted from megakaryocytes into platelets. All right. Um, they do not have a nucleus. They're very small. Platelet counts run from 150,000 to 400,000. If we have too many platelets, we say it's thrombocytosis. If we have too few platelets or a platelet count below normal, we say that that's thrombocytopenia, which can lead to this condition called petechia. All that is just small red spots that look like tiny bruises on the skin. But platelets help with hemostasis. Don't confuse that with homeostasis. Hemostasis is just how we stop bleeding and damaged blood vessels. Platelets stick to basically the broken surfaces of those capillaries, and platelets release this chemical called serotonin. It causes the smooth muscles in the walls of the broken blood vessels to contract to help prevent bleeding. So here's just a summary slide of kind of what we've talked about so far. All right, plasma. So now we've switched from the left side of that picture chart that we talked about an hour ago to the right side, plasma. 55% of your blood volume is plasma, 92% of your plasma is water, contains a lot of organic material. Remember, this is very viscous. Viscosity refers to how fast the blood flows. If your blood is too viscous, your blood flow will become sluggish. If the blood isn't viscous enough, your blood will flow too quickly. Both conditions will make your heart work harder. Your blood plasma will help transport gases, nutrients, hormones, vitamins, helps regulate your pH, maintains your fluid and electrolyte balance. We have plasma proteins, albumins, globulins. We don't use those proteins as an energy source. Remember, the albumins have that greatest influence on that colloid osmotic pressure. And I know that we haven't talked about colloid osmotic pressure, but that's actually going to be what's partially responsible for that 20 liters going out and that 17 liters coming in that I've been kind of hinting at a couple times now. So when we look at our plasma proteins, we mentioned albumins, globulins, and fibrinogens. Fibrinogen, you will need to know fibrinogen. Fibrinogen plays a big role in blood coagulation. You will need to know that. And remember, I talked about that 20 and that 17 and that 3% that's remaining. If that lymphatic system doesn't pick it up, you'll get edema. And that's just basically water accumulation in that tissue space. And if you don't eat enough protein, we'll have this condition called hypoproteinemia. Hypo means under, protein means protein, EM means blood, and IA means condition of. So hypoproteinemia. Hypoproteinemia means basically a low plasma protein concentration. This can be a result from like starvation, a protein deficiency diet, or it could be like an impaired liver that can't synthesize plasma proteins. And either way, you'll see water accumulation or edema in the tissue spaces. And, that goes back to that 2017 that I was talking about. And So albumin and these other proteins, they're going to help regulate this water movement between the blood and the tissues by maintaining that colloid osmotic pressure of blood plasma. So the plasma proteins help control the blood volume and directly affect blood pressure. Gamma globulins, they are produced by plasma cells, which are differentiated from B cells from the lymphatic tissues. So here, B cells from the lymphatic tissue. All right, so we know oxygen, carbon dioxide. We also have nitrogen in there as well. Plasma nutrients, amino acids, simple sugars, nucleotides, lipids are transported in the blood. Even though I said nitrogen really, it's also dissolved in the bloodstream, but it really has no physiological function. All right, plasma. Remember, plasma carries glucose from the small intestine to the liver, where it can be stored as glycogen or it can be converted to fat. If blood glucose concentration drops below the normal range, glycogen can be broken down into glucose. Remember that. Most of these are taken to the liver where they are stored or converted back to the body when the body needs them at that time. We also see lipids in the bloodstream, phospholipids, cholesterol. All right, we also have these non-nitrogenous substances, non-protein nitrogenous substances, or NPNs. Urea, basically, that's what we get when we break down protein or protein catabolism. We also have uric acid. That's what we see when we break down nucleic acids. Amino acids, that's when we break down proteins as well. You know, we chop up proteins because remember, amino acids are the building blocks of proteins. Creatine is that stored energy in phosphates. Remember, we get that energy from phosphate. We break off that phosphate and transfer that other phosphate over to the ADP and skeletal muscles. We talked about that. Creatinine is a product of creatine metabolism. We also have this lab test called BUN. It stands for blood urea nitrogen. And that can indicate how healthy it's a quick glance to indicate the healthiness of a kidney. It looks at basically your blood urea nitrogen. It lets us know if your kidney is not excreting urea in normal quantity due to some type of impaired renal function. Obviously, it's not going to be your only kidney test that we look at. We can look at your creatinine level. So there's your BUN, your creatinine. We can look at creatinine clearance, and we can look at the clearance of specific medications as well. So plasma electrolytes, we also call them ions. Since they ionize in water, they do conduct electricity. Remember, these are absorbed from the intestine, or they can be released as cellular metabolism. Some of the ions that we find, or electrolytes that we find in the blood plasma: sodium, potassium, calcium, magnesium, chloride, bicarb, phosphate, sulfate. Obviously, sodium and chloride are going to be the most abundant, but if you remember back from your pH lecture way back when, of these ions, or of these, which one would be the most important in maintaining your blood pH? It's going to be bicarbonate. Remember, bicarbonate does a lot of buffering. So bicarbonate would be the one that would be most important in maintaining the pH of plasma. All right, hemostasis. Remember, hemostasis is how we stop bleeding. We can do this by three methods. We prevent bleeding by we create this vascular spasm. The blood vessel kind of closes in on itself and kind of stops the bleeding that way. We create a platelet plug. And then we also we do this whole blood coagulation. And this is, we're not talking about if you accidentally chop your arm with a chainsaw, cutting a tree, and have like a huge, blood vessel injury that's going to require surgical intervention. We're talking about minor, small blood vessel injuries. So in this happens, or this communication occurs, because we have this inner lining of a blood vessel we have these endothelial cells that's going to make all of this happen. So with a vascular spasm, it's going to be stimulated by basically the clotting or the breaking of this small blood vessel. And we're going to see this endothelin be released, and then basically it's going to be a vasoconstrictor. It's going to close off that blood vessel. It's a peptide, and we're also going to inhibit nitric oxide and prostacyclin. And both nitric oxide and prostacyclin are vasodilators. If you remember from several chapters ago, we talked about nitric oxide being a vasodilator, and that's how the drug Viagra works. So if we inhibit a vasodilator, we are actually promoting vasoconstriction. So with vascular spasm, your that blood vessel and the smooth muscle also contracts, promoting that vasoconstriction, which is going to slow your blood loss, and hopefully that end of that blood vessel is going to close off completely. And that's only going to provide short-term relief, about 30 minutes worth of relief, and that's going to allow time for the other two methods to come into play. So this vascular spasm, that's only going to be short-term, about 30 minutes. And that's going to give enough time for this platelet plug formation and coagulation to work. And then we also have serotonin. We talked about serotonin a little bit before, to cause that vascular spasm. Platelets are going to come in and release serotonin to cause that vascular spasm and more vasoconstriction to decrease that blood loss. So now with a platelet plug formation and coagulation, we can break it up into two different stages. We have primary hemostasis and secondary hemostasis. So primary would just be platelet plug formation. So here is primary, and blood coagulation is secondary. With the platelet plug primary, all that is we're going to have platelets come in, release serotonin to promote vasoconstriction, and once the platelets are exposed to collagen, platelets are going to kind of become really, really sticky and form this platelet plug. And that's all primary hemostasis is. Secondary hemostasis is blood coagulation. This is where we talk about the clotting cascade. We have that extrinsic pathway, the intrinsic pathway, the common pathway, and it gets really involved. So from here, it's going to be a little bit confusing. the blood coagulation pathway, it's very effective, and it occurs in about 5 to 15 minutes after the injury. We have our platelet plug, and this blood clot is going to form in a very stepwise process called the clotting cascade. And we'll look at the clotting cascade here in a few slides. And like I said, we have the intrinsic mechanism and the extrinsic mechanism. There's 13, there's actually 12 different clotting factors that we use. Vitamin K is very necessary. Definitely remember vitamin K is necessary for functioning of clotting factors. And then we also have these things called procoagulants and anticoagulants. And it says here, major event is the conversion of soluble fibrinogen to insoluble threads of fibrin, which traps blood cells. And then it says conversion of prothrombin to thrombin is critical to the formation of a blood clot. So one thing that I'll point out, when I say extrinsic and intrinsic, extrinsic means a tissue factor pathway, and intrinsic means a contact activation pathway. And I know a lot of this is very confusing, and we'll see really how confusing it is over the next several slides. Hopefully by the end of this, the clotting cascade, a lot of this will be less confusing, and hopefully it won't be more confusing. But this is this clotting cascade is something that you will need to put some time and effort into learning, because it's definitely going to be on the exam, and you will need to know the clotting cascade. All right, so this is just kind of like a rough picture of how a platelet plug forms and how we do a blood clot. You can see that, we have the break in the blood vessel wall, and that blood escapes. Then we have platelets come in, and we form that platelet plug. And then we have our 3 steps: our vascular spasm with our serotonin, and then we have our platelet plug that comes in with platelets bind to the rough surfaces or to the collagen. And then we have our blood coagulation, and those are our coagulation factors that we'll talk about that we haven't discussed yet. So the first part that we'll talk about is the extrinsic pathway, or the extrinsic clotting mechanism. And remember that I said that the extrinsic pathway, or extrinsic means tissue factor pathway. So it's triggered by blood coming in contact with tissues outside of the blood vessel, or damaged wall of the blood vessel. Damaged tissues release this thing called tissue thromboplastin, and it's also called factor 3. It's not found in the blood, but it's actually found in your brain, lungs, and platelets. And this is where the clotting cascade begins. It's going to involve a multi-step process that has several other clotting factors involved. And basically there's going to be 12 of them. So here, thrombin is an enzyme that's going to convert fibrinogen into insoluble fibrin threads. We actually mentioned that, I think, up here. Fibrin threads are going to stick to the damaged blood vessels, trap blood cells, platelets. This is another example of positive feedback, where we're going to make it worse, make it work, make it worse, in hopes that the body resets itself. So we're going to clot, we're going to clot, and we're going to clot. It's going to promote additional clotting. And we can measure the extrinsic side. We can measure that blood test to evaluate how well the extrinsic side is doing. If you ever heard of a PTT, sometimes, actually, I should probably put a PTT in there. That's a blood test that we'll use. APTT or PTT. We'll do that. All right, on the intrinsic side, remember the intrinsic side means contact activation pathway. So it can start without any tissue damage. It's activated when blood comes in contact with a foreign substance, such as like collagen, in places where it shouldn't be. So like inside the endothelium of a blood vessel wall. And it's triggered by this factor 12, or called Hageman factor, or Hageman factor, and it's found inside the blood. And as the extrinsic clotting mechanism happens, this begins a sequential activation of several other different clotting factors. So, and we'll see how this formation of factor 10 happens, and then we have this this other pathway called the common pathway, or the final common pathway. So we're going to have an extrinsic side, an intrinsic side that's going to form into a final common pathway. And I know, like I said, it's confusing, and it's going to remain confusing, but you're going to need to work it out, and you're going to need to study this. All right, so just kind of muddle through me with the next few slides. All right, so our trigger here for the extrinsic side is damage to a vessel or tissue. On the intrinsic side, basically our blood is going to come in contact with a foreign substance, such as like collagen. Our trigger or our initiation here is tissue thromboplastin. And tissue thromboplastin is factor 3, and we use Roman numerals. On the intrinsic side, Hageman factor is factor 12, or Hageman factor is factor 12. All right. Calcium. Calcium is vital to the clotting cascade. Calcium, vitamin K, very vital. Series of reactions involving clotting cascade and calcium, leading to the production of prothrombin activator. Prothrombin activator. Both sides are going to use this thing called prothrombin activator. All right, prothrombin activator and the calcium ions cause the conversion of prothrombin, are going to basically convert prothrombin to thrombin. And, I said there's the extrinsic, the intrinsic, and we have this final common pathway, or the common pathway. Basically, this is going to be the final common pathway. So some textbooks will lump in the they'll have like an extrinsic, an intrinsic, and then they'll leave. And then they'll either call it the final common pathway, or they'll leave it as extrinsic and intrinsic. So they'll have extrinsic, intrinsic, and then a combined extrinsic and intrinsic. And that's what this textbook does. I like to leave it as extrinsic, intrinsic, and then a final common pathway. So then we have this thrombin that's going to cause a fragmentation, and then the joining pieces of fibrinogen to fibrin, And same again here, fibrinogen to fibrin. So when we look at the different factors, you're going to need to know them. I think the easiest way to memorize them is just to memorize them 1 through 12. And then figure out where they play in the extrinsic, the intrinsic, or the common pathway. So here you can see that, the first, the clotting factor 1 is fibrinogen, clotting factor 2 is prothrombin, 3 is thromboplastin, 4 is calcium, 5 is proaccelerin. Now we don't have a 6. There is no clotting factor 6. We used to have a clotting factor 6 called accelerin, but now we know that it's actually 6 is actually a combination of 5 plus 10. So it's actually a combination of this one plus this one down here. So 7 is the serum prothrombin converting accelerator. 8 is anti-hemolytic factor. 9 is plasma tissue or plasma thromboplastin component. 10 is Stewart power factor. 11 plasma thromboplastin antecedent. 12 is Hageman factor. 13 is fibrin stabilizing factor. All right, so how do you remember this? You memorize it. Or, there's a mnemonic. You can create your mnemonic. The one that I remember is frogs play tennis, cats prefer sunbathing, and perhaps some penguins have fun. So that's how you can memorize it if you want to use that mnemonic. All right, so one thing that I'll say here real quick, hemophilia. Hemophilia is just a disorder where bleeding is severe and prolonged. Hemophilia is due to a deficiency in factor 8 or hemophilic factor. All right, so you can see, the sources here. And, I mentioned that we have an extrinsic pathway, an intrinsic pathway, and then a common final pathway. And that this textbook, most textbooks will separate out the extrinsic, the intrinsic, and the common. And that this textbook will kind of lump. We'll do the extrinsic, intrinsic, and then for the common final, it'll lump both the extrinsic and intrinsic. So you can see here the extrinsics. Here you can see the intrinsics. And then wherever you see extrinsic and intrinsic, that is what I will refer to as the common final pathway, or the final common pathway, or the final pathway, or the common pathway. However you want to call it. All right, so are you ready? Here is the clotting cascade. There are different versions out here. Find your version, find what version you want to memorize. They're all going to be pretty much the same thing. So if you, we'll just go to the internet, clotting cascade, and type in images. You can come up with this image. And it will be, let's accept all. You can memorize this. Your intrinsic, extrinsic, common pathway. You can look at this one. Here's your intrinsic, here's your extrinsic, here's your common pathway. I like this one as well because it will. I actually use this. I have a copy of this on my lecture, like when I do the in class. I like it because it's color coded, and I also like it um, because it has like your enzymes or your catalyst enzymes on there too. So this what I have here is more what the textbook has, um, but I like this version a little bit better. So pick one and learn it. So here is just this is the extrinsic side. So here we're going to have some sort of tissue damage. Um, and with tissue damage, we're going to see that, remember, our first step, if we go back up here in the extrinsic, is damaged tissue releases tissue thromboplastin or factor 3. So we have factor 3 is being released, and then factor 7 comes into play. And then in the presence of calcium, we're going to form factor 10. And that's it for the extrinsic side. On the intrinsic side, remember, on the intrinsic side, we have it's triggered by blood comes in contact with a foreign surface such as collagen, and we start out with factor 12. So we have blood that comes in contact. It's going to go, then we have that factor 12, and then it says factor 12 is activated to form factor 11, and that's activated to form factor 9. And then we have this factor 8 that comes in with calcium to form factor 10. Now, I'm actually going to pull up this images. I'm going to pull up this image that I like because remember I said that I like this because it has the enzymes in there. So if we're looking at the extrinsic side, factor 7 comes in, and then in the presence of tissue factor, we're going to get converted into factor 7A, and then in the presence of calcium, that factor 10 is going to go into factor 10A. On the intrinsic side, we start out with factor 12, and then when it says activates, so here we have these activates. So what does all of these activates mean? Well, here we have contact activator. We have, factor 12 gets converted into factor 12A, and factor 12A is actually the enzyme that's going to convert factor 11 into factor 11A. So when we look at factor 9 gets converted into factor 9A in the presence of factor 11A and calcium. So I like this one a little bit better because it tells me exactly what factors are the actual activators, because I like to know what are the activators. All right. So then we have down here the common pathway. And you can see how, calcium is big involved in both the intrinsic, extrinsic, and final pathway. All right, so some key concepts that I want you to remember. With the extrinsic, damaged tissue releases tissue thromboplastin, which is factor 3. It's going to activate factor 7, And then in the presence of calcium. Calcium is our friend. It's going to combine and activate factor 10. On the intrinsic side, blood clots on the foreign substance activates this Hageman factor, factor 12, which activates 11, which activates 9. And then in the presence of calcium activates, or with factor 9 joins with factor 8 and platelet phospholipids to activate factor 10. So basically, once both the extrinsic and intrinsic come to factor 10, that's going to be the start of our common pathway. So then we can see that 10, that factor 10 combines with factor 5, and in the presence of calcium, produces this prothrombin activator. And then also in the presence of calcium, prothrombin activator gets converts prothrombin or factor 2 into thrombin, which is factor 2A. Thrombin converts fibrinogen, factor 1, into fibrin. And then thrombin activates factor 12, and that stabilizes this fibrin clot. And then also thrombin will combine with factor 5 to produce this prothrombin activator as well. So our end result is going to be this fibrin clot, and that's what we want out of the clotting cascade. And that's basically the clotting cascade in a nutshell. It is very confusing, I know. There are a bunch of videos out there. Khan Academy does a great job. There's hour-long videos that you can watch about clotting cascade. I would recommend definitely watching some more videos on the ins and outs of clotting cascade, because I know that I don't do it justice. All right, so we're gonna move on. So what happens after we have a blood clot? How do we get rid of a blood clot? So, with a blood clot, it's going to pull those edges of the broken blood vessel together, and while squeezing that serum from the blood clot. And remember, a serum is just that plasma minus the fibrinogen and minus most of those clotting factors. And then we have that growth factor, that platelet-derived growth factor, that's going to stimulate the smooth muscle cells and the fibroblasts. Remember, blast usually is a precursor that means to create something. So those fibroblasts to repair damaged blood vessel walls. Plasmin is going to digest or break down those fibrin threads, breaks down fibrinogen and dissolves that blood clot. And then we have this tissue plasminogen activator and streptokinase that will help dissolve blood clots. So plasminogen is converted to a clot dissolving substance. So if you have a defect with plasminogen, blood clots are not going to be broken down. So we're going to need tissue plasminogen activator and streptokinase that will dissolve blood clots. But if we don't have this plasminogen, we're not going to be able to dissolve those blood clots. All right, so abnormal blood clot formation. So we know we've heard of a blood clot. We actually call a thrombus is basically a blood clot that forms abnormally in a blood vessel. If you've heard of DVT, deep vein thrombosis, that is a thrombus or a blood clot that forms abnormally in a blood vessel. An embolus is a blood clot that has broken off and is starting to move. Thrombosis is the blood clot that is moving. Or I'm sorry, thrombosis is a blood clot in a vessel that's supplying a vital organ like a brain or the heart. So if you have, you've heard of the commercials about, atrial fibrillation, and there might be a blood clot in your heart that can break off and go up into your brain or into your lungs. Yes, that would be a thrombosis. In an infarction would be what happens if that blood clot did go to that blood vessel. I'm actually going to move that. So we're going to talk about, so we have that thrombosis that is lying in that vital organ. And if that blood clot travels and blocks a blood vessel in an organ, it's now called an embolism. So a pulmonary embolism would be a blood clot that is blocking the blood flow to the lungs. Or a cerebral embolism would be a blood clot that is blocking blood flow to your brain. So then we would see infarction would be, because we are now blocking blood flow, we would see infarction, which is death of the tissues, which block blood vessels due to the blood clot formation. And then atherosclerosis is just an accumulation of the fat in the arterial linings that can cause the abnormal blood clot formation. And here you can see this is the lumen, or where the blood would flow. Here's your artery wall, and here's kind of like a normal lining of your artery wall. So here's where the blood flows. Here's your artery, and here's all that plaque buildup. That's too many Big Macs. That's too much Taco Bell. That's not enough exercise. So that's all that's atherosclerosis. All right, so DVT, deep vein thrombosis. Basically, this is a clot in pooling of stagnant blood. Stagnant just means you're not moving around. It's usually in your lower legs or your femoral veins, or in your pelvic veins of your pelvis. It can be a very serious complication. You can see circulation issues within your legs. You can see issues when you are on long periods of immobility. If you work at your desk 8 hours a day, or if you're on a long flight, typically they say, every 2 hours, get up and move around. I usually, my little Apple Watch, yells at me, I have a little stand up every hour. And usually if I'm like recording a video, I might pause the video and just kind of like do this with my watch, because you can cheat this way and get your steps in. Or I'll just pause the video and I'll get up and walk around my office, or go to the bathroom or something like that. Just get my steps in, and basically want that skeletal muscle contraction to contract your muscles, so that when you contract your muscles, you're actually contracting your veins and moving your veins around to help push that stagnant blood back up to your heart. But basically with DVT, you can break off, that clot can actually break off. and lead to an embolism, a thrombus, an embolism, and go in and block your pulmonary artery, and you have a pulmonary embolism. It can go up into your brain. You can have a cerebral aneurysm. But basically, just avoid long periods of immobility. Get up on your feet, move around every now and then. If you have to sit on an airplane, stand up every so often, every 2 hours or so, get up, go to the bathroom. It also says wear compression stockings or take anticoagulation medicine. So if you are have a surgery where you're not going to be mobile as much, they might put you on a medication called Lovenox, and they'll give you a little injection, and that'll kind of help thin your blood out a little bit to help prevent the deep vein thrombosis. All right, prevention of coagulation. So this is like what I was talking about with the Lovenox. But in non-medicine form, what can your body do to prevent coagulation? So we have the normal blood vessels that typically we don't have platelet coagulation or platelet accumulation. We don't have clotting factors that typically will cause our blood to clot, because we have these healthy endothelial cells that produce these prostacyclins, or this prostacyclin called PGI2. And it's a prostaglandin that basically prevents these platelets from becoming sticky and sticking to the inner walls of the blood vessels. And PGI2, it's also a vasodilator to help keep those capillary beds open. And then as the clot forms, it also prevents the clot reaction from spreading. And we have this antithrombin that's going to inactivate additional thrombin, and blocking its action on fibrinogen. And we mentioned before that we have these basophils and mast cells that release this heparin. Heparin is an anticoagulant. It's going to inhibit the formation of prothrombin activator. Remember, prothrombin activator let's see, where is prothrombin activator? It's going to be right here. And the action of thrombin on fibrinogen. So basically, we are working in the final common pathway, this prothrombin activator to fibrinogen. Prothrombin activator to fibrinogen. So it's going to work kind of down here in this area. All right, so if we have a defect or an alteration or malfunction of this PGI2, remember PGI2, it's a vasodilator, and it prevents platelets from sticking to the walls of the blood vessel. So if we have a defect of PGI2, this prostacyclin, this defect would lead to vasoconstriction, or constriction of your blood vessels, as well as abnormal blood clotting. So things that inhibit blood clot formation, the smooth lining of the blood vessel, and how does it do it? It prevents activation of the intrinsic blood clotting mechanism. Remember, the intrinsic side activates based on foreign substances like collagen. Prostacyclin is a vasodilator and prevents platelets from adhering to the vessel wall. Fibrin threads are going to absorb thrombin. Antithrombin is going to inhibit the action or interfere with the action of thrombin. And then we have heparin from basophil and mast cells. Remember, heparin is an anticoagulant that's going to interfere with the formation of prothrombin activator. Now, some disorders of your blood. We've already talked about sickle cell disease, where your red blood cells kind of lose that fluffiness and that round, and they kind of look like the Grim Reaper with his sickle, and causes sickle cell anemia, pain, other symptoms, cyanosis. So you have your sickling red blood cells, and that's going to block circulations, which is going to make your cyanosis and your low oxygen even more profound. But here you can see some different erythrocytosis or chronic granulomatosis diseases. Hemophilia, remember, was the lack of clotting factor 8. Von Willebrand's disease causes bleeding. It's going to be less severe than hemophilia. You don't necessarily have to know this chart, but I just put it in there. All right, blood groups. So, type A, type B, type O. This was actually first identified in 1910. Once we actually started looking at the microscope, before that it was like, you lost some blood? Let's give you some blood. Oh, you died? Okay. And it wasn't until 1910 that we actually kind of figured out why. When we look at red blood cells, we notice that there's these things called antigens that are on the surface of red blood cells. All antigens are just proteins. And they're actually not proteins. They're glycolipids. But we'll just say that they're proteins. We'll call them antigens. So they're antigens that are on the surface of the red blood cell. So you can either have nothing on the red blood cell, or you could have an A antigen, or you can have a B antigen on the red blood cell. And if you have a safe, and knowing if you have a nothing, an A, or a B, if you have a nothing, an A, or a B, or you could have an A and a B, knowing this will let you know what kind of blood is safe to transfuse to that patient. And if you transfuse the wrong type of blood, what you'll get is this thing called agglutination, and it's basically a clumping of red blood cells, and that's called a transfusion reaction, is the agglutination. So we're going to have to know what the blood type is of the donor, what the blood type is of the recipient, and that will determine whether or not it is safe to transfuse that reaction. All right, so we've already said that the antigen is on the red blood cell. And when we're looking at reactions, so the antigen is on the molecule, and if there is a reaction to take place, the antigen is the molecule that will evoke an immune response. If the immune system finds that there is a foreign antigen in the body, it's going to produce antibodies against this antigen. Now, antibodies, this is what is in the bloodstream. So these are proteins in the bloodstream or in the plasma that are going to react against a specific antigen. Again, that's on the red blood cell. So if we have an incompatible blood transfusion, that donor red blood cell will evoke an immune response because the antigen on that red blood cell will evoke an antibody reaction. So you're going to have a reaction between the antigen on the donor red blood cell and an antibody from the recipient's blood, causing agglutination. And basically, the antibodies are going to fight things in the body that it doesn't want. We have put blood in the person that the body doesn't want. It's the wrong blood type. So that recipient is going to produce antibodies because the antigen on the donor's blood is evoking an immune response in the recipient. So we have this agglutination, and like I said, it's a clumping on of the red blood cells when the antibody from the recipient encounters an antigen on the donor's red blood cells. And rarely is that serious enough to invoke or cause death. But nowadays, with modern technology, rarely do we see transfusion reactions. But if we do see those, you're going to see anxiety, breathing problems, facial flushing, headaches, severe pain, perhaps some jaundice. All right, so how do we determine your blood group? Again, we're looking at the presence or absence of those two antigens on the red blood cell membrane. Remember, we have A, B, and if you have type AB blood, you have antigen A and antigen B. And if you have type O blood, you're not going to have any antigen. So you're going to have one of four combinations: nothing, A, B, or antigen AB, or antigen A and antigen B. So these antigens, like I said, they're glycolipids on cell membranes. And in order to have this transfusion compatibility, we have to make sure that there's not going to be an antigen-antibody reaction that will cause agglutination and destroy the red blood cells. So for an example, if let's say that you have type A blood, you're going to have antigen A on your red blood cells. If you have type A blood, now this is the confusing part. If you have type A blood, you're going to have these things called anti-B antibodies in your plasma. So that means you cannot receive transfusions that have the B antigens. So you cannot receive type B blood and you cannot receive type AB blood. You can only receive blood that has type A, that you can only receive blood that does not have the type B antigen on it. So if you have type AB blood, you will have both antigen A and antigen B on the surface of the red blood cell. So therefore, you could receive blood that has the antigen A, the antigen B, or nothing on it. So if you have type AB blood, you're good to go as far as receiving blood. So this slide is a little confusing, but we'll just break it down. So if you have type A blood, remember we have antigen A. If we have type B blood, we have antigen B. If we have type AB blood, we have both an antigen A and an antigen B. If we have type O blood, we don't have any antigens. We don't have an antigen A and we don't have antigen B. So far, that's where students, they're like, yep, got it. I understand it. Now, this is where they get confused. Remember, antigen is on the red blood cell. Antibody is in the plasma. Remember, this antibody, it's what's going to invoke or evoke that response if there is a reaction. So in type A blood, we have type anti-B antibodies. So that means if we receive type B blood or type, I'll write it type A B blood, I'll write the B in big to kind of highlight the B portion of AB blood. If we receive type B blood and or type AB blood, we're going to trigger this anti-B antibody, and we're going to trigger this immune reaction. And I'll just say immune reaction agglutination. If we have type B blood, we're going to have this anti-A antibody. So if we receive type A blood or if we receive type A B blood, we're going to trigger that anti-A antibody and we're going to get an immune. Pen eraser. We're going to trigger an immune response. Now, if we have type AB blood, we don't have any antibodies in our system. So we can receive type A blood, we can receive type B blood, or we can receive type AB blood. And I should say here, with all of these, we can receive type O, we can receive type O, we can receive type O, because O is a good blood. O has no antigens on there. Now, unfortunately, if you have type O blood, you have that anti-A antibody and you have that anti-B antibody in your bloodstream. So if you are transfused, if you receive blood type A, blood type B, or blood type AB, I can't write, then you're going to get an immune reaction. So the only type of blood that you can get is type O. All right, so obviously you don't have to know this chart. This just shows you how the types of blood by race in the United States. Type O blood, 45%, type AB is 4%, American Indian is 79% type O, only 1% AB, 10% Korean, Chinese American. So you can see that, the majority of the people have type O blood, and the minority have type AB blood. All right, so this is looking at the antigens themselves. We have this is our red blood cell, and then we have this antigen molecule. There's our type A, there's our type B blood. And then there's our type A blood, and our type B. So there's our type AB blood. And then our type O actually doesn't have any antigens on them. And then for our bodies, here you can see the anti-B antibodies because we have type A blood, so we have anti-B antibodies. Here we have type B blood, so we have anti-A antibodies. Here we have type AB blood, so we're not going to have any antibodies. Here we have type O blood, so we have anti-A and anti-B antibodies. All right, and this is just showing you kind of what happens with agglutination. So here we have, it looks like type A blood because we have the A antigen with the anti-B antibody. And then we are exposed to the type A or the type A blood. No, I'm sorry. We're exposed to type B blood. I'm sorry, because we have the anti-A antibody. And you can see how now we have this reaction where the red blood cells are kind of hooking up together and the anti-A antibody is linking up with this antigen antibody receptor to kind of clump up these red blood cells. That's called agglutination. So that's your transfusion reaction. All right, so we have these things called universal donors and universal recipients. Universal donors are type O blood because they lack any type of antigen on their red blood cells. They don't have the antigen A or the antigen B. So type O blood can be donated to anyone. They're not going to have any type of agglutination, no transfusion reactions, because type O blood does not have the anti-A or they don't have any antigen A or antigen B on their red blood cells, so they're not going to cause a transfusion reaction. Now, a universal recipient is type AB blood because they have the antigen A and the antigen B on their red blood cells, so they have no anti-A antibodies and they have no anti-B antibodies. So because they have no antibodies, they can be transfused any type of blood. Unfortunately, going back to our chart, they have the lowest percentage of blood type. Now, type O blood has the highest percentage of blood type. So theoretically, we should not have a blood shortage if all of the type O people out there donated blood. But a lot of people don't donate blood for one reason or the other. But so know your blood type, and if you can donate blood, please do. All right, so type AB blood is the rarest blood type out there. So far, we've only talked about the types of blood, A, B, AB, and O. But we know that we don't just have those types. We have the A positive, B negative, AB positive, O negative, stuff like that. So We have another piece of the puzzle that we have to look at. We have the we'll talk about the pluses and the minuses and what that means here in a second. But now a person with, and we already know that a person with type A blood can donate to a person with type A or type AB blood. And we already know that a person with type AB blood can receive blood from all blood types. But now we kind of have to look at the pluses and the minuses. So if we have a person that has A negative blood, obviously their preferred blood type is going to be, your preferred blood type is going to be your own blood type. So this category is going to match up with this category. Always take your own blood type first. However, if that's not possible, the only other blood type for A negative is going to be O negative. Now, if we have A positive blood, then our other combinations or our possible choices are A negative, O negative, and O positive. Now, the difference, we have, and I know we haven't talked about what the positive and the negatives mean, but if we have a negative can be donated to a positive, but a positive cannot be donated to a negative. So here, and I'll just write it here, a negative can be donated to a positive, but a positive cannot be donated to a negative. So here, a negative cannot be donated to a positive, or a positive cannot be donated to a negative. Okay, so here we have a positive, a negative. So negative can be donated to a positive. All right, so here we have a negative. A positive cannot be donated to a negative. And here we have an A and a B, so that's why we can do the A negative, the B negative. So if you have AB positive blood, you can actually receive blood from anyone out there. If you have O negative blood, you can only receive O negative blood. And if you have O positive blood, you can only receive O negative and O positive blood. So let's see, rarest blood types. So let's just do blood type. Let's just look at Northern California Blood Bank. Let's not go to Facebook. Images. All right, so AB negative is the rarest blood type. So AB negative, so this is going to be your rarest blood type. B negative is your second rarest. Then AB positive. A negative. O negative. B positive, A positive. And O positive. Okay. All right. So now what do the positives and minuses mean? Oop. So it's named for basically a rhesus monkey. That's how we kind of first discovered this. And just like with the antigens and the antibodies that we discussed earlier, one other thing that we noticed was this antigen D. So we have the antigen A and the antigen B that we make up our blood type with. But we also have this antigen D, as in dog, and that's also on the cell membrane. So if we say that you're AB positive, you have this antigen D, as in dog, as well. So we say that you're AB positive or O positive, that you have this D antigen on your cell membrane. If you're negative, if you're Rh negative, that means you do not have this antigen D on your cell membrane. Now remember, if we go back, negatives can donate to positives, but positives cannot donate to negatives. So an Rh negative blood donated to a positive person is a no reaction. We saw that here. Negative can donate to a positive because there is not an antigen or that antigen D on that red blood cell. And anti-Rh antibodies only form when an Rh negative person in response to the presence of red blood cells with Rh antibodies. So that's when a positive donates to a negative person. So that's when we are doing this. If we have a positive donating to a negative person, Rh positive to an Rh negative person, could result from a transfusion of Rh positive blood. Now, here's the caveat. So this initial transfusion, the first time that you do this, the first time that you donate a positive, Rh positive to an Rh negative person, it's not really dangerous because it's going to take several days for these antibodies to appear in your blood plasma. And by that time, pretty much everything is done with. So that initial transfusion is not really going to do anything. However, your body's going to remember this. And if you have a second exposure to this Rh positive blood and you're an Rh negative person, now that you have already developed these antibodies, if you are exposed again, that second transfusion will cause your blood cells to agglutinate, or that transfusion reaction will occur. Now we see this sometimes in a condition called erythroblastosis fetalis, or it's also called hemolytic disease of the newborn. And it's basically where mom is Rh negative and baby is Rh positive. Baby 1 is Rh. So mom is Rh negative, baby 1 is Rh positive. And remember that first exposure, nothing's going to happen. But that second, now mom is pregnant again, and mom has that second exposure to the Rh antigen D. And during vaginal delivery, mom's blood and baby's blood gets mixed. If mom has that second exposure, then things could be kind of complicated. So that second exposure, the fetus developing in an Rh woman, that's when we can see serious complications. Okay, from beginning. I went too fast. All right, so here you have mom with mom who's Rh negative, baby who is Rh positive, and now you can see that mom has some antibodies starting to build up, or mom is exposed to baby's blood, and she has these antibodies starting to build up because there's mixing of blood, and then during the second, she gets pregnant again, and then now you can see that there's going to be this linkage or this reaction between mom's blood um, and these antigens. So that's what we have, this hemolytic disease of the newborn. So and you know, we can take care of it. So as long as we know about it, we can take care of it. So that is the end of this very long chapter called Blood. So if you have any questions, please let me know, and I will see you guys soon. Take care.